osteopathic medicine. He then went on to internship and then residency at Abington Memorial Hospital, followed by fellowship in critical care medicine at the University at the New Jersey Robert Wood Johnson Medical School. He then came to Madison, where he rose through the ranks as assistant professor, associate professor, and then full professor in medicine and anesthesiology. He was director of critical care, director of the Trauma and Life Support Center, and I think just about the time I arrived, I hope it wasn't related, Ken moved to Geisinger, where he has been active as an intensivist and a teaching attending in tertiary care. He was responsible for administrative oversight in critical care as vice chair of medicine and service line director for critical care medicine, and he also initiated and developed their tele-ICU system. Just this year, Dr. Wood has moved to the position I mentioned already at the University of Maryland. He's very well published. I think it's always interesting seeing the trajectory, and over the 39 articles, number one is complications associated with sedative and neuromuscular blocking drugs in critically ill patients, and the most recent is how do residents spend their time in intensive care units. So he has an area, he has a focus, and he's stayed on that throughout his life. He's edited 10 textbooks. He lists 23 book chapters as well, and he's been well supported through his career, currently having grant support from AHRQ. He has more teaching and education and service activities than I can possibly mention, but I should highlight the fact that he is a much sought-after speaker. I counted over 200 national and international talks, 22 visiting professorships or named lectureships, and along the way he's received a number of awards, including our own Department of Medicine's Professionalism Award. He received the Teaching Award. He has also received the Society of Critical Care Medicine's Presidential Citation and the Geisinger Health System's Excellence in Government Advocacy Award. He's here for Quality Week here at UW Health, and it's really our good fortune that he was able to stay and give grand rounds for us today. Entitled Major Pulmonary Embolism, a Pathophysiologic Approach to Diagnosis and Therapy. Please join me in welcoming back Dr. Ken Wood.
Thank you. Appreciate it. Well, thank you, Dr. Page. It's a privilege to return. And I say, I guess, this in the context of having been away for 6 years. I think many of you have been here for a career. I was here for almost 20 years, and I would just say to you, you ought to appreciate the extraordinary care that's rendered here, particularly through the Department of Medicine. The exquisite level of expertise, consultative care is really extraordinary, and I think you ought to be very proud of that. Sometimes you need to go away to recognize that, but it really is extraordinary care. Yesterday, Dr. Georgiou shared with me the extraordinary acuity now in the TLC, which has some of the highest severity scores in the country, and the actual mortality is half what it should be. So I'm sure that translates into multiple disease states throughout the system. So really appreciate the extraordinary opportunities and care I think that this department has, and particularly this university. So it is genuinely a privilege to come back. It was probably 22 years ago where I stood in the exact same place and gave grand rounds. I did a talk on pulmonary embolism, and it's actually the same talk. So if you want to leave, it's the same slides. I'm pretty static, I think, as you know. I have no industry support. My research is federally funded. It's in systems engineering applications to medicine and venous thromboembolic disease. So what I'd like to do is provide an overview, and not being hematologists and seeing world-class hematologists in the audience, it's always a bit intimidating, so I apologize in advance if I get some of the secret handshakes wrong in hematology in terms of how this works. But I'll try and do it at the very simplistic intensivist level so at least I can understand it. But it will be a physiologic overview and a look at risk stratification from a physiologic perspective. And then particularly use shock as a discriminator for outcome. That's the traditional discriminator for thrombolytic therapy, and I think as we'll highlight, that threshold to use thrombolytic therapy has actually been liberalized and probably will continue to be liberalized. And look very much at the evolving strategies for massive PE. Now, we use the term massive because it's been equated with hemodynamic instability. And there's probably nothing further from the truth necessarily, and we'll review sort of the evolution of that process. So this is what we'll look at, and like anything else, it's probably helpful to look at it through the past. Virchow, who was really probably one of the most eclectic physicians in the 19th century, discovered venous thromboembolic disease, if you will. So the father of modern anatomic pathology, looking at cellular function to organ function, actually was a member of the Reichstag and was there for 13 years in the Radical Party, vigorously debated Bismarck. He was responsible for the Berlin Code. But what he's known for is reconciling the debate that occurred with Paget and a series of the other giants in the 19th century medicine as to where do clots come from. Do they spontaneously form in the pulmonary artery, or do they actually migrate? Now, Virchow thought they migrated. The others, Cuvelier and Paget, thought that these things actually just spontaneously formed in the pulmonary artery. So Virchow conducted an experiment where he took berries, put them in dogs, embolized the berry, and what he observed was the phenomena of stasis, the phenomena of coagulation, and the phenomena of vascular irritation. So he described actually the consequence rather than the mechanisms. It wasn't until 1924 that Ashkoff actually put it together in the contemporary framework we use today, defining Virchow's triad as stasis, hypercoagulability, and intimal damage. PE and VTE things seem to happen as events in a 50-year interval. It really went from the 1840s to the 1880s before Picot recognized the severity of the disease, that it could be lethal, and we could probably stop the remainder of the lecture today with the penultimate and the ultimate sentence, that the rise in pressure on the right heart, which it might fight to survive, actually may lead to cardiac arrest. And that really was recognized well over 120 years ago. Some of the landmark work that leads to where we are today needs to be appreciated to provide a spectrum, really, of the advances that have made in the disease. This is one of the classic papers from Homans in 1934, really before anticoagulation, where he describes a dangerous form of venous thrombosis, uncommon enough to make its study difficult, yet so fatal to make its recognition a matter of importance. Lead article, New England Journal, 1934. So PE strikes many. So familiar with David Bloom, had the Bloommobile, traveled with the Third Army in Iraq, F-150 Ford truck, dehydrated, cramped in a tank, complained of leg pain, ultimately found to have factor V deficiency and died of PE. Mario Lanza, weight loss program in Rome, sedated, intense level of sedation and non-movement, awakened, phlebitis, dropped dead of probable pulmonary embolism. For those from a different generation, Heavy D, 8-hour flight back from Cardiff, Wales for a performance for Michael Jackson, died. Similarly, Derek Thomas, spinal cord injury. George Patton, C5 spinal cord injury, died 2 weeks later of a massive pulmonary embolism. Tammy Stewart, chronic venous thromboembolic pulmonary hypertension, died from clots. So I present this only in the context to realize the diverse etiologic backgrounds and disease state demographics that PE inhabits. It's a medical disease, a surgical disease, a post-op disease. It's something that happens very frequently, and it strikes everyone. So pathophysiologically, the first cartoon really looks at the etiologic mechanism, which are the valve cusps. And the recesses of the valve cusps are where clots begin to form. This is particularly true in surgical patients, where the clots form in the bottom of the soleus plexus. This occurs intraoperatively. Inhalation anesthetics dilate the venous capacitance reservoir, tends to create shear force, tissue factor, and that in conjunction with stasis creates an engaged and inflamed endothelial surface. So the actual histopathology portion of this, you can see the cartoon version, and then this is actually the area of the lumen. This is the valve. And there's variance in organization of the clot that begins and it propagates from the valve recess all the way around the valve and then into the lumen. These are the lines of Zahn. And the ones closest to the endothelium, which implicates tissue factor in many of these things, are the red cells and the fibrin that join together and propagate. And as the valves
compress and mitigate flow backwards, there also are little interstices that create non-laminar flow, which eventuates into a vortex clumping of cells and coagulation factors. So the pKa actually with stasis decays from 5 down to 0.1. So this induces an inflammatory state in the endothelium. This is the classic description that Wessler used in the 1950s, that the endothelium, meaning the soil's planted and fertilized and ready when the actual clotting factors come. So the activated vascular endothelium plays a major part of this elaboration of tissue factor. And one looks at the hypoxia, the induction of inflammation, and simply sepsis, tissue factor from surgical release on monocytes contributes significantly to the formation of the clots here. We're designed not to clot. Our vascular endothelium has a whole series of mechanisms to prevent clot and maintain flow. And sepsis, inflammation, surgery change that. And so there's a very delicate relation between the immune system and thrombosis. So if you look at what Streptococcus produces, streptokinase. Yersinia produces a plasminogen activator. So it's all done in teleologic terms because from an evolutionary standpoint and protective phylogenetically, this relationship between thrombosis and the immune system is pretty tight. And one might argue that it creates, as the initial picture showed, a fibrin net that traps bacteria. In the evolutionary battle between bacteria and humans, the bacteria actually sometimes win. They produce streptokinase and they digest the fibrin clot. So it's really a walling off if you think of it teleologically. So this is sort of a 6-hour window of stasis with the pKa dropping, inflammatory response. You can see the magnitude, the aggregation that occurs that this cartoon depicts, where the white cells are then migrating into the area. Various receptors occur, inflammatory response, tissue factor, activation of the clotting cascade. So this all occurs at the microvascular level and is the beginning of what would be the major clot that eventuates into a deep venous thrombosis. So I was very fortunate I was here to work with an extraordinary pathology department, attended many of the autopsies after ICU rounds, and was able to participate in many of these. These are pictures. This is what a clot looks like, so keep that in mind. This is not a small, tiny, minuscule clot that would land in the LAD. These are between 2 and 10 centimeters very frequently, much older oftentimes. And when they migrate and embolize, think of this with thrombolytic therapy and the extent to which the new recommendations to use catheter-directed therapy, a series of other things we'll examine, have to digest this clot. When one uses streptokinase or TPA, the literature would suggest that only 25% of this clot could be digested in the first day, so it doesn't evaporate. The idea that one could have a cardiac arrest, mechanically fracture the clot, use thrombolytics, and there's no clot at the end of the arrest is a myth. It doesn't happen. You can't digest that much clot that quickly. And clots are usually multiple in time and space. It's rare, if ever, that an individual has one singular clot. And this is embolectomy cases where you can see these are the large, but they're usually clots in the shape of the venous system that are throughout the lung. So pulmonary embolism is common, it's lethal, and even in 2015 it remains significantly underdiagnosed. How common is it? Looking at pooled data, trials, observation series, one could argue that close to 1% of an admitted population in a hospital will probably have a VTE event or a pulmonary embolism. So at large places that would admit, say, 300,000 patients, or rather 30,000 patients a year, 1%, it's about 300 cases. So whether we recognize it or not, large tertiary quaternary institutions will probably have one clot per day. PE remains very lethal. 2/3 of the patients who die of pulmonary embolism do so within the first 2 hours. 2/3 of people who die do so in the first 2 hours. What's equally underappreciated from the autopsy series is that there are many people who die of pulmonary embolism from small clot. Statistically, not everyone dies from anatomically massive clot. So there are several implications, one particular implication from those two observations, one of which an evidence-based approach to what I'm going to present to you is almost impossible. Any disease state where the people who die do so in the first 2 hours is just almost impossible to put in a randomized controlled trial. Secondly, it would suggest a very dynamic interplay between the underlying cardiopulmonary architecture and the size of the clot, that a small clot with poorly preserved cardiopulmonary architecture can manifest similar presentations and outcomes as a very large clot in patients who have well-preserved cardiopulmonary architecture. So it's a dynamic interplay between the two. And lastly, the antemortem diagnosis of pulmonary embolism, even this contemporary time period, probably only occurs in 30% of patients. That means 70% of the patients who die of pulmonary embolism never have the disease even suspected. So that's done with a retrospective review, autopsy data, looking for any mention of PE in the chart. Absolutely none. So hence the idea of prophylaxis and developing pretest probabilities. We'll focus on massive clot. You can see that's a bit of a different animal than non-massive clot. So again, the literature is permeated with definitions that relate to anatomic size. I think you'll see that that probably isn't a good correlate. It's the underlying physiology. So this has been interpreted, even though it says massive, it's been interpreted to mean hemodynamically unstable. And most literature series, that would be between 5 and at most 15% of all pulmonary embolism cases. But you can see that the outcome data for this group, particularly death with its attribution to PE, is not trivial. So how do we really define that? I think we could all rely back upon the Potter-Stewart definition when he was called to define pornography. He said, "I know it when I see it." And I think what a lot of people see with pulmonary embolism is big clot. But again, autopsy data would strongly suggest that many, many people die of anatomically smaller clot. And it's a relationship between the cardiopulmonary status and the clot size. So the convention really arose from James Dalen work out of the Dexter lab in Boston in the 1960s after the first angiogram series. And it was defined as an angiographic obstruction of more than 50%. And probably most everyone in this room would tolerate a clot of 50%. People that are elderly, debilitated, significant underlying cardiopulmonary disease, the average clot burden is far less than that. People who have clot burden of more than 50% never survive to be studied. And there's been an evolution to physiologic characterization, looking at right ventricular dysfunction, hypotension, since 1995, which has really changed the way we look at pulmonary embolism. So I'd encourage you to look at it a little bit differently than anatomic size. You know, in the ordinate is mortality, on the abscissa is severity defined by embolism size and cardiopulmonary status. Certainly the worst case of any disease results in sudden death, but the combination of embolic size and cardiopulmonary status that precipitates cardiac arrest in the reported literature would have a mortality of only 70%. It's a lot better than most cases of cardiac arrest. So the corollary to that is 30% of the patients with cardiac arrest from pulmonary embolism probably will survive. So if you have a 21-year-old trauma patient who has a tib-fib fracture and a soft leg cast, who has shortness of breath and arrests, this is the person you provide all the level of aggressiveness. Intracardiac TPA, and depending upon your institutional capabilities, many go right to ECMO in those circumstances. So it's a very, very aggressive approach because these patients aren't doomed to fail. 30% will survive. So at the other end of the spectrum, the failure to precipitate right ventricular dilatation. So in the original angiographic series, one needed to obstruct about 30% to produce elevations in the mean pulmonary artery pressure. So the subsequent echocardiographic literature would suggest that one would need to obstruct about 30% of the outflow tract to actually dilate the right heart. So the corollary to that is that the failure to dilate the right heart has almost a zero mortality with appropriate anticoagulation, almost zero. So there are probably 12 studies now looking at sending patients home with pulmonary embolism. So the caveat is the population that, again, is stable, fair to have right ventricular dilatation. The unknown and the holy grail of the pulmonary embolism literature is to try and differentiate within this group of patients who have right ventricular dilatation, who reside right sort of on the incipient cusp of shock versus the group that actually lives over here with a mortality probably closer to a population that didn't dilate the right heart. And I think what we'll see is an evolution to using BMP, troponin, and a couple other markers to then discriminate that. And that used to be a major issue of how to do that. We'll review some of the recommendations from the new 2 meta-analyses. I guess you could argue and say I never met an analysis I didn't like, but these 2 meta-analyses would suggest that the evidence would would really strongly urge us to then liberalize the threshold to use this in hemodynamically stable patients. So in looking at an approach of risk stratification, there usually are in the critical care arena and with any sick patient, about 5 things you have at your fingertips within this golden hour. A history, a physical, EKG, chest x-ray, ABG, really. And you have to look at the physiologic footprint that a disease state, particularly PE, makes in these readily available studies. And I think what we're seeing will be an evolution away from CT being a binary yay or nay, but it's one-stop shopping. It tells you the disease or the absence of, but at the same time, the physiologic information that can be derived from CT scanning will actually look at a very effective way of creating risk stratification. So physiologically, the combination of neurohumoral factors that probably represent 10 to 15% of the increase in pulmonary impedance in conjunction with mechanical outflow obstruction precipitates right ventricular pressure loads. Ultimately, that results in decompensation, but that occurs in conjunction with ischemia as well. So the coronary perfusion pressure gradient, if your right ventricular end diastolic pressure goes up, you have to have a coronary perfusion pressure gradient. You'll see that when you lose the gradient, it's well reported in young healthy people with normal coronaries and autopsy series to have complete transmural infarction to the right heart. So clearly that plays a role. We'll examine a little bit of data with metalloproteases and the relative contribution, because many times the ischemic insult or the insult's not in one zonal distribution. It's actually spread out in multiple areas, which would argue that it's not all ischemia. It's ischemia in conjunction with something else. So those 2 things precipitate right ventricular outflow decreases, and because we have 2 hydraulic pumps in series, as we heard on teaching rounds yesterday, just wanted to make sure I was told I had to say 2 hydraulic pumps in series today. That is a determinant of left ventricular preload, loss of forward flow, loss of the coronary perfusion pressure gradients, increased cavitary volume provokes a septal shift, pericardial restraint, it migrates into the left side, loss of ventricular filling, distortion of pressure-volume relationship, all which conspire to then decrease preload. So this cascade is what happens in the first hour that requires intervention. So in looking at autopsy series, again, it highlights that although previously it was thought to be just a coronary perfusion pressure gradient abnormality, there's lots of areas of focal necrosis. And there's evolution, I think, in the literature suggests that this area of necrosis, probably related to the activation of stress-induced metalloproteases, precipitates increase in fibrosis. And so we look at long-term outcomes in pulmonary embolism, distortion, pressure-volume relationships, pulmonary hypertension. The question, I think, may be beyond thrombolytic therapy, beyond anticoagulation, is how might we attenuate what's a clearly evolving picture of inflammation. And so there is data now in animal models looking at metalloproteases, those from a generation that would remember Pac-Man. The metalloproteases are really involved in myocardial remodeling, so embryologically it's important, but it's sort of the patchwork quilt that one is able to use with myocardial infarction and remodeling, and this happens as a consequence of activation from oxidative stress. It bypasses the inhibitor, and ultimately, if we can translate some of this animal model data, so it would be ironic to think that we have a PE and the first thing you do is take some doxycycline, but that's actually what the animal literature would suggest to attenuate this response, and that may be a major part of the dilatation and the stress and the myocardial dysfunction with residual fibrosis that actually occurs. So physiologically, the shape of the pulmonary vascular resistance curve looks a bit like this. A Miller index of about 25 or so would constitute a 50% anatomic obstruction. So the pulmonary impedance begins to rise thereafter. So the relative benefit of thrombolytic therapy, decreasing right ventricular end systolic wall stress, decreasing the actual dilatation, and being able to augment filling of the left side, is predicated upon the ability to move a small change here. And in that part of the inflection curve, it'll work really well. Over here, it probably doesn't matter. So the key is to define the population at risk where thrombolytic therapy might have the greatest benefit. So from an aggregate physiologic model, this translates into increased impedance, higher pulmonary pressures, consequent obstruction, neurohumeral components, volume loads, pressure loads, increases in systolic wall stress, ischemia, metalloprotease activation, decompensation, loss of forward flow, 2 pumps in series, increased venous tone, and this cascade is one that we can use to then ensure that pulmonary embolism is incorporated in the differential diagnosis of undifferentiated shock. Because you have about an hour, so you have to have a paradigm to take to the bedside for respiratory failure, for cardiac failure, to ensure that you hierarchically and appropriately prioritize things that are important that could kill people. Because if you miss your priority and rely purely on etiologic lists, you may have actually put the list in the wrong place. 2 parallel pathways, physiologic resuscitation in conjunction with generating a differential diagnosis. So having said that, the 3-compartmental model with volume in the capacitance reservoir generating venous return to the right heart, which is 2 pumps in series that empties into a common impedance bed, the characterization with pulmonary embolism would be somebody who's cool, massive pulmonary embolism, anatomically massive or physiologically massive, would be a patient who's cool, clamped, hypoperfused, narrow pulse pressure, libido reticularis, high impedance, high resistance, reflective of low flow because of compensatory increase in catecholamines, segregating lesion back to the right hydraulic pump via the capacity to look at differentiating of left and right heart failure. The lungs are clear, the chest X-ray is clear, the neck veins are up. Within 30 seconds, one ought to be able to then isolate a hydraulic lesion. The differential diagnosis of right heart failure is exquisitely limited to PE, RV, infarct, decompensated pulmonary hypertension, so on. There's very few things that will selectively knock out the right heart. Obviously, in a young, healthy person, it's much easier to do that. So as you go back to the original angiographic series, this is the first report from McIntyre's group. You can see the PaO2 for that population, pulmonary artery pressure. And again, these are people with no disease, right atrial pressure modestly elevated, cardiac index just a little bit above norm. And there's linearity. In people with underlying cardiopulmonary disease, there's virtual linearity between the magnitude of the clot burden and the physiologic consequences. That relationship is distorted dramatically in patients who have significant underlying disease. So for those who have significant underlying disease, for a much smaller clot burden, there's significant increase in pulmonary artery pressure, increase in pulmonary impedance, and a much lower cardiac index. So it underscores the dynamic interplay between those 2 components. So at the bedside, we have these core things that are available. So it's important to take a history. So this would be the CPC unknown part of the grand rounds. So that night in Phoenix, I wasn't at my best the whole match. I couldn't get enough air. I thought it was because I was in Minnesotan, this being the upper Midwest. This is appropriate to your sister state. It was used to cold weather, and Arizona was messing with my metabolism. So the chief complaint would be hot air messing with my metabolism. It hit me again when I was in Oakland. I ran out of breath. Woke up that afternoon in sweat, took a deep breath. This is number 3 to 4, and this is a true story, actually. Severe pain, couldn't stand it. Had pneumonia, sounded just like it. So who is this? Jesse Ventura. Navy SEAL, starred in the Predator series. Subsequently had another PE. So the history and the physical are very important. So as we look at the exam, keep in mind that probably only 3/4 of the people who have PE will be dyspneic. Probably only half will be tachycardic. So the signs and symptoms make it almost enigmatic at times. Similarly, the readily available studies like the EKG, this is the original paper from McGinn and White describing electrocardiographic core pulmonality, the S1Q3T3, but that's unusual. The vast majority of the people who have pulmonary embolism tend to have ST wave abnormalities. There's revolving data looking at the anterior T-wave abnormalities, so I can distinctly remember 2 cases when I was here over the 20 years where patients presented with chest pain, shortness of breath, BMP, troponin, went to the cath lab and dropped dead when they went home because the anterior T-wave wasn't ischemia. The troponin wasn't related to myocardial, it was related to a pulmonary embolism. So anterior T-wave inversion is a major part of it. It's a repo abnormality, probably something that will resolve and can be used as a barometer to define the efficacy of LASIK. So classic presentation, S1Q3, and you can see the terminal vectors to the right side, and ST wave abnormality. So again, you don't have many things to create this hierarchical differential diagnosis. Chest x-rays can be helpful, certainly to exclude other things. This is the original from Hampton and Castleman, if you ever wondered where Hampton's hump came from, a non-IRB protocol, I'm certain, but they took patients after they died and did x-rays, and then they did the autopsy, found the PE, went back and correlated the PE, the infarct size, in the dead patient that they did the x-ray on. So suspect that would have some challenging times getting through the IRB today. So physiologically, if one looks at multiple inert gas techniques, hypoxia from PE is actually not the traditional VQ mismatch. It's related to shunt, near shunt effect. So if you have no blood flow, you will, in a compensatory way, vasoconstrict very crudely. So your goal in life is to match your V's and your Q's. So if you have no Q, the goal is to have no ventilation. So eventually you recannulate through that, and I think that's the dominant reason the midget techniques would suggest that it's a right to left shunt. So the correlate to that on a chest x-ray is a consolidation atelectasis, which makes PE so difficult to discern from other areas. The evolving literature will look at BMP and troponin as really a discriminator, BMP being a surrogate for cavitary dilatation, pretty good correlate with echocardiographic dilatation, mean pulmonary pressure elevation, and troponin for two reasons. One, the actual gradient of loss of coronary perfusion pressure with ischemic infarct, but the digestion by the little Pac-Man that sort of takes metalloproteases to the forefront. So those two reasons. But they, however they arise, they create a risk stratification tool. So as the hierarchical prioritization unfolds, looking specifically at how do we rule this out, CT scans have supplanted VQ scans. I would think that's fair to say the radiation and some of the recent recommendations. But it really should be more than a yay or nay. There's an extraordinary amount of information that can be pulled out of the CT scan that can assist with risk stratification, multiple scores to define anatomic level of obstruction, cavitary dilatation, flux back into the superior vena cava, size of the left atrium, and many of these are actually evolving to the point where I think they'll be effective risk stratifiers. Certainly the new dual energy technique might be a very convenient way to assess the efficacy of reperfusion beyond just hemodynamics. Good data, at least 3 or 4 studies, would suggest that the residual degree of pulmonary artery obstruction is a harbinger for not only recurrent COT, but 6-month mortality. So it may be at some point we start to look at that routinely. There are other studies that would suggest that EKG or ECG synchronized CT scan allows a calculation of ejection fraction. Again, it's more information in conjunction with simply it is a clot. Has the right ventricle, how's it work, what's the ejection fraction, interrogation of physiology that I would suggest probably would preclude the need to do echo. Once the diagnosis is made, the severity is derived with the history, physical, hemodynamics to define the use potentially of thrombolytic therapy. This is a fascinating study that just recently came out that had the highest predictive value for poor outcome was the inability to fill the left atrium. So if you think about the 2 hydraulic pump in series model, if you have an impedance problem on the right side leading to the left, and you can't fill the left side, this actually may be something, again, I don't know how your CT folks at Maryland, the CT folks are starting to read and incorporate some of these things into the clot because there's a whole almost algorithmic approach that in a very short period of time eventuates in ECMO. So getting some level of risk stratification is very important early on. So if we look at the cardiac arrest patient, there is, again, limited literature, but this is the spectrum of major pulmonary embolism. This is a population that we really need to worry about what to do and when to do it. The limited literature would suggest there's better outcomes when lytics are given earlier during the arrest. And that can be a big challenge, obviously, because of the uncertainty of the diagnosis, the disease, but if your pretest probability in a 21-year-old college student or trauma patient who has a tib-fib fracture, who's short of breath, high neck veins, they're probably far better off getting a lytic agent, having the ECMO team and the cardiothoracic team immediately at the bedside than they are going down the pathway into oblivion of not having any treatment. But the literature that's limited would suggest earlier therapy. Well, I think if we go back to antiquity, it's been clear that coldness of the extremities is a bad sign. So the hydraulic pump version of that would be the impedance is very high, the compensatory response to low flow, and it's a catecholamine surge. But it's true with any disease state. So I went back and resubsetted the original data from Boston and UPET, and I think this underscores the absence of a relationship between anatomically massive clot and outcome. So segregating that data into shock and no shock, you can see that you look at outcomes, shock obviously in all series is about a 5 times increase in mortality, but anatomically massive clot unaccompanied by shock doesn't have a significantly increased mortality. And then similarly, UPET, which until recently was the largest trial ever done, actually submassive clot had a higher mortality than massive clot. So it underscores the dynamic interplay. It's not the size of the clot. And the consults that I get for somebody who's got this big honker of a clot, who's hemodynamically stable on room air oxygen, who's actually reading their paper, their outcome, again, we'll talk a little bit about size in terms of residua that's left, but acutely there really isn't any need to think about lytics in that population. So this has eventuated into, this happened to be the algorithm that I had put together just as a physiologist, really segregating into shock, and we're going to talk about shock, non-shock. All these patients should be heparinized, and certainly the ED literature based on pretest probability would tell you that if you have a high or intermediate probability before your diagnostic studies are done, you should be heparinized. If you have low probability, so if you're in a shock state with your probability and you can be anticoagulated, you should be. In the world we're living in, I would suspect here, if not many other places, echo has and will supplant the stethoscope. So handheld echoes at the bedside and the capacity to really define right ventricular cavitary dilatation. The absence of right ventricular dilatation doesn't exclude clot, but excludes clot as the cause of the hypotension. To fail the hypotensive test, you have to fail the right ventricular test if it's pulmonary embolism. So this is an algorithm that's published, and you can migrate down through the presence or absence and define what your studies are. But I got to underscore CT scan probably helps. Echo, again, I can't emphasize the extent to which I believe that echo, particularly in critical care, will supplant much of what we do. The key is developing the competencies that lead to the credentials so that people actually know what they're looking at. That's the big danger with proliferating any technology. So it has the capacity to define disease states and alternatives, and this would be the classic finding. So left heart, right heart. You can see preservation of apical contractility with paralysis of the right ventricular free walls, McConnell's sign, dilatation of the right heart, migration of the septum over into the left side, dilatation of the right heart. So this would be a classic finding of a patient at the bedside for pulmonary embolism. And so there is a small literature, but again, given the proliferation of echocardiography at multiple levels, being able to actually undertake a TEE where one could actually see the clot, and the limited studies that have done this, show an equivalence to CT scanning. And given the expertise that evolves, these were done with impunity. There were no complications. So think about that. In the emergency department, somebody comes in with the constellation, high risk, history, physical, gets intubated, ventilated, undifferentiated shock. The capacity to make the diagnosis in 15 minutes is now available. And this is an illustrative example of what that would look like. And looking out at the pulmonary artery, you can actually see that. So therapeutically, you obviously have to get the patient to survive to get the lytic therapy. So airway management's very important. So patients run on a catecholamine surge, high venous tone in response to high right atrial pressure, set of hypnotics that dilate the venous capacitance reservoir, lose the gradient for venous return that Guyton described years ago, and these patients can arrest. So remember, the shape of the pulmonary vascular resistance curve is horseshoe-shaped, and it's lowest at FRC, highest at atelectasis, and highest at over-distension. If you have an overzealous person bagging and you increase the PVR, you can fail a heart immediately. So statistically, when patients are induced in anesthesia for embolectomy in shock states, 20 to 25% will arrest. And there's no data, no predictive model to tell you which ones, but it underscores how tenuous the airway can be with severe right heart failure. Similarly, one need to be very judicious with fluids, because if the right heart is already dilated, the end systolic wall stress, the biggest determinant of myocardial oxygen uptake, pressure, radius over thickness. So if the pressure's up, the radius is up, it doesn't make a lot of sense to actually increase that further and outstrip the blood supply and create more shear force. So Using alpha agents to vasoconstrict and generate perfusion pressure gradients is very important in that context. Important to recognize that you can worsen with treatment because the underlying physiology is shunt. So as you augment cardiac output in the face of shunt, you'll paradoxically improve, but at the same time you may decrease your saturations and your PaO2. So something to keep in mind when you're using pulmonary embolism and inotropic support and lytic therapy and augmenting right ventricular function. Similarly, there are cogent reasons to use nitric oxide in this population just because the hemolytic events that occur, the free hemoglobin, the binding of nitric oxide and whatnot, creates an imbalance. And so in my experience, when somebody is in that extremis state, nitric oxide as a pulmonary vasodilator is used at the bedside, 10 parts per million. The interventional radiology team or whomever does your interventional work is called, as is cardiothoracic surgery, because there needs to be a sequential plan, particularly if you're going to use systemic lysis to define success or failure of the lytics. So in looking at lytic therapy unequivocally works in terms of anatomic diminution of clot burden. No question, and this is a panorama of all the original studies. There's virtually no question that it diminishes that. Over what time window does it do it? Well, if you look at the overall size of the clot burden, in 24 hours, the amount of resolution with heparin versus lytics, they only digest about a quarter of the clot in the first 24 hours. That's it. Heparin, you don't get hardly anything. But what you see is that by about 2 weeks, and this is true in every single study that's been done, it's about the same. Just about every study. There's a couple recent that would suggest there's some conferred benefit. But in general, and so as you look at all the major studies that have been done, there's equilibration. There's essentially clinical equipoise in terms of physiologic function. There's a couple recent ones that have tracked people a little bit longer looking at echo to suggest we had a liberalized therapy. But in general, the benefits early on. So I think what changed and will change practice are these two meta-analyses just published. Previously, the use of thrombolytic therapy for the ACCP and other recommendations was purely based upon hemodynamic instability with risk-benefit crafted. So the addition of Pytho and Topcoat and a series of others allowed for an N to define where the use of this might reside if you use meta-analysis to guide your evidence-based practice. And this would suggest that in the population with pulmonary embolism, and again, the carve-out here is people who do not have a dilated right heart. So the shock population, the intermediate risk, meaning hemodynamically stable with right ventricular dysfunction, this meta-analysis would say that that's a population that the evidence would say these people should be lysed. This has enormous implications in transitions of practice of what we do today, particularly related to the cost, and I think as you'll see, the extraordinary complications. And this is segregated into the population that had hemodynamic instability, but the price that we pay is bleeding, an enormous amount of bleeding. These aren't true, and these are research trials. Bleeding in real-life observational series actually probably are much higher. But this is the first meta-analysis and the one that follows to show that there's improved in mortality and decreased recurrent clot. Never been actually proven in meta-analysis. All of WAN and a series of others done before said there's no reason to do that. So subsequent, another year later, second meta-analysis looking at the aggregation of studies, the population that's high risk, meaning hemodynamically unstable, when you then break it down into the intermediate risk, right ventricular dilatation with hemodynamic instability, positive yield for the patient in terms of diminution in recurrent clot and mortality. But though when you put, the analysis together with low and intermediate risk, there was no conferred benefit. So it underscores that certainly in the high-risk patient, but I think the take-home message that I got from both of these against the background of the evolving literature would be that there probably is cogent rationale and evidence to expand the lytic threshold. The price you pay is bleeding. So if you have an efficacious therapy that has unacceptable risks, so 3% risk of bleeding in your head with a mortality of 50%, that's a big problem. So there are now 3 trials looking at interventionally directed therapy, catheter-directed therapy, Some have used ultrasound guidance, so ultrasound is thought to effectively disaggregate fibrin reversibly, so it allows the lytic agents to get in, do a better job. The first trial was randomized control with heparin, and you got what you expected. It was more or less a safety trial. The reality is, if you use lytic therapy, you improve the pulmonary impedance, you actually decrease the pulmonary pressure. The Seattle 2 study, again, used the ultrasound device to be able to go in and do that interrogation, open it up. And these are doses of about 1 milligram an hour of TPA, 15 to 24 milligrams. These are really small doses. And actually, in one of these trials, 9 people had overt contraindications to thrombolytic therapy and were given thrombolytic therapy at that low dose, had no bleeding. So it really changes the dynamics of how we think about the use of lytic therapy. The last study is probably, I think, maybe the most telling. Again, none of these are the big randomized controls that will change practice tomorrow. But what it suggests in all of these is that the amount of bleeding and complications is almost non-existent. So if you have skilled technical people that can do this, and we then by definition have, I think, some evidence to suggest we ought to expand the thrombolytic threshold, but we don't have bleeding, I think each institution will have to define how they would go about doing this. I think from my read of this, the diminutions in the cross-sectional area, the improvement in pulmonary hypertension, and all that echocardiographic improvement is exactly what you'd see with lysis, but you don't get the bleeding. Based upon the last study, there seemed to be no evidence to support the need for the ultrasound component, which adds appreciable cost to this, but this is a series of things in evolution, only 3 studies, but my gut is that this will supplant what we've traditionally done with thrombolytic therapy. So if you see a clot, you want to try and get a sense of where and when it will fail, and there is data based on echocardiograms of the extent to which the characteristics of the clot might warrant more aggressive either catheter or surgical embolectomy. This is where, again, echocardiography helps. Certainly, as you lyse clot, you may actually change your end-tidal CO2, because traditionally people give a thrombolytic agent and cross your fingers and think, well, 4 hours, let's see what happens. But we have to actually devise a structured way to look at that. What Paul Stein has suggested, and this is, again, observational database interrogation, is that patients who are unstable actually don't get very much thrombolytic therapy, and they don't get filters, in contrast to the patients who are unstable, who do get lysed. Placing a filter in that group is associated with significant, very significant conferred benefit. That's the shock group. That contrasts with the JAMA publication by Mazzardi about what we would do in general with filters, but keep that in mind with the shock population. This is very true in the embolectomy literature, that the mortality is much less when individuals get a filter with that. So this is Trendelenburg's original article. It was a procedure he devised that waited to do. Never did successfully, actually. And that was his instrument, and the first case of ECMO actually was done for PE. And Paul Stein, again, has interrogated the database, and depending upon institutional expertise, if you can't get catheter embolectomy, you can't use lytic therapy. In my mind, this is the hierarchy. There's a whole school of thought in other institutions that do surgical embolectomy that there's no point in doing any of that, particularly the patient at high risk, to wait for the catheter, to wait for this. You just go right on pump and you actually do the case and you take the clot out. So there is probably some variance in institution, and every institutional expertise is a little bit different. The development of ECMO actually originated when Gibbon in 1930 was assigned to monitor a patient who was a 59-year-old post-cholecystectomy who had a PE and just watched her die. So he spent the next 25 years working through the heart-lung machine. And the contributions he made with that are extraordinary. And so what we've seen with the seizure trial and the other uses of ECMO is a real proliferation of ECMO. So Maryland has what's called a critical care resuscitation unit. So all transfers in for anything from the entire state go to this unit, except for level 1 traumas. So there's algorithmic approaches to disease state management, and right next to the critical care resuscitation unit, which then sends patient where we need to go, is a lung resuscitation unit. It's a 4 to 6 bed unit. Last year did 130 cases of ECMO. So an algorithmic approach that migrates right down the pathway, that if you're failing and you're about ready to die and you have intractable hypoxia that can't be taken away from mechanical ventilation, ECMO has a role, but there are no trials. This is anecdotal empiricism. So summer of 1974, Watergate. Nixon resigned in August, right? August, got pardoned September 8th. Well, actually, on September 8th, he had his third DVT. He'd had DVTs traveling from Egypt and Vietnam in the past, but because of Watergate, elected not to get it treated. And he actually just used elevation and didn't treat anything. We had his PE early in October. His pardon occurred September 8th. So right on the time of his pardon was when he had his DVT that evolved into a PE. Well, eventually he got worse and had to actually undergo a venogram. It had just a humongous clot that extended into his IVC. And because there were no filters at the California hospital where he was, he had his iliac ligated, actually had hemorrhagic shock thereafter. So this was right when Haldeman and Dean and Ehrlichman were all subpoenaed. And so Nixon was similarly deposed, but there were three docs, and these are the people from Maryland, Hopkins, and I think GW, who went and did an evaluation. He was deemed too sick to travel. And so we never heard Nixon's testimony because he was deemed too sick to travel. The actual trial went on, so we never know precisely what he knew or didn't know, but it was because of DVT. So that's what a trap filter clot looks like. That's what it's supposed to do. And I think another major change in practice unfolded, at least in my mind, from this manuscript, because with the use of retrievable filters, it's really appealing. If you get somebody with a bad heart, high risk, big clot, could they tolerate the next one? I think many of us said, well, there's no data, but empirically we'll just drop a filter in this person and we'll feel better about that. Well, this study answered that question, I think. So criteria for severity and filters went in, longitudinal anticoagulation, didn't change anything. No difference. Actually, there's higher mortality in the filter group. So I think it really calls into question placing filters prophylactically in people with high risk, and whether that in fact should be something we ought to think about, a significant change in practice. So I'll just close really with a very brief comment because I think the world's changed a bit with these two meta-analyses, which have liberalized the thrombolytic threshold. Previously, the question was segregating lesions within that hemodynamically stable group. So if you look at large series looking at dysfunction and those who stay stable, 9 out of 10 people will be stable. There's a small minority, small fraction that deteriorate and get worse. And the question is, should they have been lysed? What are the indicators? BMP, troponin, heart fatty acid protein. What do you use to then put a risk factor to say the risk of thrombolysis actually is less than the risk of them dying? And so now where we've got meta-analyses, I think some recommendations to liberalize the thrombolytic threshold, and then we have a technology that enables the use of thrombolytic therapy to be undertaken almost with impunity in terms of bleeding risk. I think it's really put the VTE holy grail into a major transition in terms of the direction we would go. So I'll close with that level of uncertainty because I certainly don't have the answer as to the right way, but it's really in the last 3 to 6 months a disease state treatment in evolution, and I think we're evolving away from the nihilist approach that previously dominated that literature in terms of thrombolytic therapy to using more of it, using it with catheters, and hopefully aborting the longitudinal sequelae. So I really appreciate the opportunity to come. It's a privilege to be back, and thank you for the opportunity.
That was terrific, Dr. Wood. We have time for perhaps 1 or 2 quick questions and quick answers, and I'll just ask you to, actually we have a microphone, so we don't even need you to repeat the question. Clint's got the microphone there.
Ken, thanks for that wonderful talk. I'm wondering if you're aware of ongoing studies of catheter-directed thrombolysis that are appropriately powered with meaningful clinical endpoints that are maybe going to be more convincing or maybe help define the patient population in whom or what that threshold of severity is in patients with intermediate risk should be?
Yeah, very good question. I'm not sure anybody, at least I don't know the precise answer. I know Sam Goldhaber in 2007, after the original catheter-directed therapy came out, said that this is something we ought to be doing. So what we have are those 3 studies. I believe there are several in a formulative state, but if you look at just the lytic, hemodynamically stable patient for lysis, I mean, that took almost 10 years to put a major powered study together to say it works. So I'm not aware of what precisely would be on the horizon. I do believe there are some that you read about, people in a preparatory phase, but it clearly will answer the question because, if you look at the VTE literature, using ultrasonic stuff hasn't shown benefit there. It clearly didn't show it in the last study. So then you get into the extensive costs that could be incurred with this in the population. But preliminarily, and Cal has written on retrospective observational series and the abolition of the pulmonary hypertension against the background of limited complications, I think it's a pretty strong argument that practice is going to be changed before we see the RCTs.
I think we're going to have to stop there. If there are further questions, Dr. Wood might be able to take them here up front. I want to thank him for an outstanding grand rounds.
Thank you.